Today we're talking a bit about disparities. I'm going to breeze us through a couple of studies that are ongoing here in Los Angeles. I'm also going to channel Rafi Landovitz, so I'll speak faster when I get to his part. Just to give you a sense of what we're going to do today, just a little, very brief epi, because Mario, you did a great job on that, and it's really important to have that sense of where the virus is and where these diseases are in our county, because as academics, we need to work where the virus is, not where the light may be better or our resources may be better, but to be working where people are most impacted. We're going to talk a little bit about pre-exposure prophylaxis rationale and then hit the studies, 061, 073, 069, and 077. These are from the HIV Prevention Trials Network. As we know, that's a national and international network of studies funded by the National Institute on Allergy and Infectious Diseases and a number of other institutes at NIH, including NIMH. Thanks, Chris, for all of your support. Okay, good. I'm not going to spend a lot of time on this. We talked a lot about how HIV is concentrated among MSM. We are the second largest concentration of AIDS cases nationally in LA County. And we have a distinctly MSM environment. About 85% of cases in LA County are among MSM. In one way or another. There may be other comorbid risk groups, but MSM, we've been talking about this for a long time, and it still catches people unaware that this is an MSM epidemic in Los Angeles. And in particular, it affects black men who have sex with men. Want to talk a little bit about some of the foundational research, and this is the place where I started to get really kind of upset about LA County. HPTN 061 was the largest and first prospective study that was conducted about black men who have sex with men in the US. Why is that important? Because we're over 30 years into the HIV epidemic, and we had to wait 30 years before the first study was conducted that focused particularly on black men. We were one of the cities that were involved in this. There were 5 other cities. And what we were looking at was to find out what is the HIV incidence rate for black men who have sex with men in the US who are at high risk. This is not across all black men or all black men who have sex with men, but black men who are engaging regular unprotected anal sex. Is that in this large sample that it was about 3% incidence per year in black men who are having sex with men. It was about double that for young men who have sex with men. And the background prevalence in HIV in Los Angeles County was about 7%. We were 1/6 of the sample and 40% of the incident infections in the national study. Clearly something is going on here in our backyards, and we need to pay attention. This was a wake-up call for me and really focused me that what I need to be focusing on, not so much in HIV prevention, is across the board, but among black men. A follow-on study about using pre-exposure prophylaxis, about beginning to think about integrating additives to the HIV prevention picture that's out there, not just asking people to use more condoms or to change their sexual behaviors, but to begin to add tools within the HIV prevention network. Greg Millett has shown very clearly that black men who have sex with men are having sex in the same way and at the same rate and the same venues. Everything is identical to gay men from other racial ethnic groups. So I want to put it out there very clearly that this is not a pathologizing sort of a statement about we need to work with black men. It's not pathologizing. It's about working where the virus is and people are most affected. Oh, I hit the wrong one. Pre-exposure prophylaxis, we're not going to spend a lot of time on this, but it's the idea that you bring a medication on that is known to show effect in combating HIV, and you bring that medication on when somebody's HIV negative, so you boost the immune function in the event of an HIV exposure. There's some data that's been shown that this works across a few studies, particularly with MSM. and particularly when using a pill called Truvada. Truvada is a combination product of two medications, tenofovir and emtricitabine. Both of these are anti-HIV medications, and they are used as a single combination tablet in the context of risk reduction counseling and condoms, usually in HIV-negative people. One of the really good things, talking about disparities, is that some of the advocates have been very good in this state to be able to get Truvada to be part of the Medi-Cal, to be covered by Medi-Cal. So one of the things to take home is to remind people that even if you're working with disparities populations, these men have access to these drugs, and the first line of defense is always, well, we can't get them because you're on Medi-Cal or LA Care or, you know, whatever. But the reality is we can get these medications to men using ETARs and different sorts of techniques. So if you have questions, give me a call or talk with us at the center. We'll certainly walk you through these sorts of ways to get people onto these medications who need them. The important thing about a tablet is no tablet will work if you don't take it. So there's been a couple of failed trials in using PrEP where people have just not taken the medicine, and guess what? People get infected at the same rate, whether you're on the active medication or the placebo. If you're on the medication, you're not taking it. So we know that there are some problems with adherence that can limit the influence of its effectiveness. So what we wanted to ask was, if you made available pre-exposure prophylaxis to high-risk black men in 3 U.S. cities, would the black men first, who are at risk, decide that it's worth doing to integrate a biomedical intervention with their sexual protocols? And, you know, what sorts of side effects might you see? What sorts of adherence might you see? Those sorts of things. One of the things that's happened, because when you're looking at doing controlled, randomized clinical trials, there's a lot of attention paid in the early phases of medication development to make sure that the medication is safe. So people are all over you. Did you take your pill? Did you take your pill? Did you take your pill? How many pills you got left? If it doesn't add up, they say, you didn't take a pill. Which pill didn't you take? You know, and so they're going to look at and see, you know, how careful you were with your medication taking so that you can know whether the medication has a chance of working or not. This study says we know that if you take Truvada, that it's going to be helpful to you to avoid HIV infection. So we're not going to ask the question about how much adherence do you have. We're going to ask the question, if we make this pill available to you, will you take it? That's a different question than did you take it? So this is the first study that follows on from 061. This is a very unique HIV prevention study because it's a study that's led by black men, Daryl Wheeler and Sheldon Fields, thank you. Sheldon Fields. Sorry, I know Sheldon very well, but it's a senior moment, I'm getting older. It's led by black men and it's for black men. So this is a very strong statement of participation by the community on a very controversial topic. We know that medical ethics over the years have not been very kind to the black population in the US, and the question was, if we make this available, will this be incorporated by black men? And in Los Angeles, we have found that a lot of the uptake has been greater among young men than some of the gatekeepers in the community. Some of the gatekeepers have very decided negative attitudes about biomedical prevention, yet many of the men have been very interested in going forward. We have 225 participants across the country, 75 here in LA, and we're on our way to doing this work. The study procedures are to engage and educate black men, to test the men who test negative, will get counseling, linkage, and support, and that support will include adherence and focus on retention in the study. The study questions are, will black men initiate PrEP? Will they use PrEP daily? Is it safe for black men to use PrEP? Will black men's sexual practices change with the uptake of PrEP? One of the questions that we always want to look and see if there's something called risk mitigation, where you have this idea the medication's on board so I can regress to doing more risky things. Is it acceptable for local healthcare facilities to administer client-centered care coordination, the specific type of prevention counseling that's being administered with the medication for this study? And when we're finished, how much Truvada is in the bloodstream of black men who report taking it, and if there are HIV incidences, will there be drug resistance? One of the reasons that we're concerned about this is Truvada is a very easy pill to take. It has very few side effects. And for those who are HIV positive, it's an important part of a lifelong arc of treatment. And so what we have to be careful is that if we're encouraging a drug-resistant form of Truvada that's out there in the communities being transmitted, then we're actually trimming a treatment technique for positive people that could have differential impact on their lives. For black men in this study, they had to be 18 or older. They have to be 18 or older. Black, Caribbean black, or multi-ethnic black male, MSM, HIV negative, male at birth and identify as male, so there's no transgender women in this study, sexually active and willing to provide comprehensive and current treatment location information. We'll see them about 7 times over the study. We'll give them the opportunity to begin or end Truvada, so there's no forced entry into the medication taking. That's one of the dependent variables. There'll be plenty of physical examinations. We'll discuss concerns or drug side effects, establish a care plan, receive HIV testing and counseling, and at Vine Street, where we're running the study, we actually provide the treatment for the STDs on site, and we offer condoms. So here's what we have so far. Of the 56 men who've enrolled into the study, only 2 have dropped after 10 months of enrollment. This is pretty remarkable, and there are only 2 people, both in Los Angeles, who've dropped in the study across the nation. So this is retaining men at a very high rate. It's very popular. One of the problems I just want to point out is that disparities are interacting here to a certain extent, probably more so than some other groups, with being able to come onto the study. About half of the men who apply for the study who don't come on don't enroll because we can't, they don't want to be part of the study, or they just don't want to stay with it or whatever, provide information. Of the other half, about 40% or 20% of all of the men who are screening out because they have medical conditions that prevent them from taking Truvada. Okay, so that's a disparities issue, that they have high creatinine values, they may have untreated diabetes, they may have hypertension that's uncontrolled, they may have some other medical condition that would be adverse to starting Truvada. So it's not a majority of men who are not in the study because of disparities issues, but it does underline the fact that across our population, men don't seek medical care very frequently, and that the cost of that is that they may be showing up with medical conditions that are going untreated that would prevent them from adding a medication or biomedical approach to their sexual protocols, sexual health protocols. We've got about 2/3 of men who've started PrEP at different times. We have about half of the folks who are currently on PrEP. Of those, 80% started PrEP from enrollment, 6 started sometime after that, and 5 started PrEP and then decided not to continue. We have no adherence measure for the study while it's ongoing. We'll do a blood analysis at the end. We have the standard set of responses from people who are given medications in a trial. They get lost, they get flushed in the toilet, they go on vacation, they forget to take the medication. One man reported he wasn't taking the pills. He's not in this report. A couple said they wanted PrEP, but then decided they didn't want it after all and never picked up the medications. But on the whole, men are consistent and report missing a pill only here or there. We've had no one withdraw from Truvada for any medical reasons. One of the concerns that we had, you can kind of look at this, but I want to focus on the bottom part here, that we've had 0 seroconversions among the men who are on the study. We had 1 acute case that was detected at admission, which lets us know that we're still in this high-risk group of men. The other thing I wanted to point out is we had a man recently who had a non-medical related serious adverse event. Well, it wasn't a serious adverse event, but it was a migraine condition that he went to the emergency room, and he talking to your point, Mario, about the need to instruct the structural medical system. He went in to talk about the medications he was on, and he said, I'm on Truvada, and the medical professional had no idea what Truvada was for. So it was, and this was in an emergency room. So one of the places where you would expect people to come in with sexual emergencies that might want PEP or that sort of thing, that the idea that we have this medication online, but yet some of the folks who are in the emergency rooms don't quite know what it's about. All right, we're still enrolling, and here's the important thing. If you have folks who might be interested in participating in the study, or you might be interested, here's our telephone number, 866-449-8252. It's a shameless plug, sorry. Want to change now, I'll start speaking faster, because this is where Dr. Landovitz takes over, HPTN 069. This is it will recruit 600 people, 400 men, 200 women at risk, HIV negative folks, gay men and women, and they will randomly be assigned to 4 arms, Maraviroc monotherapy, Maraviroc plus tenofovir, or emtricitabine, Maraviroc plus Truvada, and then the Truvada alone. And this is the idea to look and see if there are any benefits in terms of adverse events or toxicities to one or more of these different types of antiretrovirals for pre-exposure prophylaxis. The study is ongoing at the Care Center. It is offered in with a behavioral platform, that sort of thing. Men are over-enrolled, so there's no more men being enrolled to the study, but females are very welcome to apply. For women who are at risk, we can see that the UCLA site has 13 slots that are open for women. Adherence is being measured using WISE pill and by drug levels. It's a blinded review. In the review, there was a criterion set that if there was a less than 70% detection of the medication in the blood, they would stop the study. There was no signal sent out to stop the study. So it appears that there's at least some level of ongoing adherence in that study. And now for something completely different. HPTN 077. One of the problems with adherence is you have to take a pill every day. This is a medication that will actually provide once every 3-month shot. Actually, it's 2 shots in the butt. So the idea is it's nanotechnology formulation. The half-life of the medication is about 50 days. It supports quarterly dosing. It's safe. The tissue levels are acceptable in plasma in the vagina and in the rectal areas, and there are few drug-drug interactions expected. The data that show that this is a good medication come from work with macaques, showing that in 8 macaques who were rectally challenged with simian HIV, there were no seroconversions in the medication-treated group. And then finally, Dr. Landovitz is the protocol chair for this study, which is a great honor within the HPTN. The study is a 3-to-1 active to placebo randomization of 176 at-risk men and women not at risk. And the reason for this is because this is a phase 2A. It's a safety study. The issue is this medication tolerable? What happens is you take medication orally for 4 weeks to assess the safety and tolerability. The reason that you do that is because once you get the shot in your butt, you have it on board. So if you're going to have a serious adverse event like a liver toxicity or something like that, doc wants to know before you put the shot in that you're going to be okay. So it's still possible that you could have an adverse event, but it's a pretty safe strategy. The primary endpoint here is, after a year, is safety and tolerability, and the secondary endpoints are things like PK data, sexual risk behaviors, incidence on the product, and drug resistance. And I want to acknowledge our funders, NIMH, the CHIPS Center, the UCLA CFAR, and the HPTN.